Hello, welcome to our final episode. After finishing the 20 episodes, we went along with so many topics. It was a nice experience. I hope you find it informative. Uh, if you find that there is any things that you want to give advice of, please feel free to write it in the comments below. It will be a pleasure to read. Um, It's the last step is doing the restoration, which means it's after we finished everything inside, dealing up with the radicular and the canals. After we went with the war with the bacteria, after we diagnosed, after we have retrieved the patient from the pain he was suffering from. Now our last a step on completing our role is doing the restoration. How to choose the appropriate restoration considering the amount of tooth that has stayed is what we are going to discuss today. So let's go along. We used to hear that when we do the indoor treatment, the tooth loses its water content. But this loss does not contribute more than 99% of the water, and the water that is bonded into the organic and the inorganic components stays and do not dehydrate. Also, the changes that happen to the tooth by age, which is the dentinal sclerosis, um, and the etching that we do using the EDTA or the sodium hypochlorite, not the etching, I mean the irrigation and the chelators that we do it with the EDTA. These have an impact on the dentin, but this impact is considered minimum when we compare it to the physical and the mechanical loss of the tooth structure, whether it is in the caries or doing our access cavity and doing the root preparation. So the author is saying that the more we are conservative in opening the access cavity and doing the preparation, the more we are conserving the tooth and make it more strong and less fragile, and it can maintain the mastication load on it and prevent uh, any fracture that may happen in the future. These are some elasticity modules, the young modules. I think that they are important for the researchers to get information from them. I'm not gonna go in deep. They are comparing the hardness of the dentin before and after, and these in numbers. Here they are saying that losing the marginal ridges makes the tooth loses a lot of its stiffness, which means that the MOD preparation or cavity makes the tooth really fragile. So we must be as conservative as possible. This is the case when we see that there is a great loss in the tooth. When we did the restoration, it was so close to the furcation area. Then after 3 years, the tooth became symptomatic and it was extracted, and an implant was put instead. The ferrule. We know that ferrule is... Let's explain what is a ferrule first. A ferrule is the dentinal walls that must be 3 to 4 millimeters, that the crown or the restoration will cover, and it will sit on the finishing line. So the more we have of this length, the more we are giving support to the restoration that we are putting in. So it is so important for full crown preparation to have a ferrule no less than 4 mm. So if we do not have this, in some cases we do what is called the lengthening of the tooth of the crown to get this ferrule. And what is the importance of it? They are saying that it allows the axial walls of the crown to encircle the tooth, providing restoration, retention, stabilization, and reducing the cervical tensile stresses. Here we are discussing the color change that happens after doing the endo treatment. There are so many causes. The mechanism of how chemical happens is not fully understood, but there are the suspicious, for example, because we are using NTA, 𝐏𝐻𝐢𝐭𝐢𝐴, some necrotic tissues that are inside, hemoglobin, some pigments from the drinking food. Also, if the tooth become yellowish, which means that there is a dentine thickness underneath, and this happens after when the tooth became necrotic and there is a calcification as an inflammatory response, then the thickness increases and we get a yellowish color more than a dark brownish color. We will see how can we deal with this with it further below. So let's discuss what are the restorative options. Why do we do the restoration? First, protecting the remaining tooth from fracture, preventing the root canal, preventing the reinfection of the root canal system, and replacing the missing tooth structure. The first is the direct composite restoration. We can do it when there is a minimal amount of coronal tooth structure and the new composite generations, the strength of it has reached the dentin normal strength, which means that it can, when the restoration is minimal, the comparison between an intact tooth and a restored tooth is the same. But to prevent the shrinkage that happens to all the restorations, we must do the incremental filling technique when we do it in small amounts and we build it gradually. So the direct composite is indicated when there is only one proximal surface of the tooth lost. Here are saying the emoder cavities, they lose a lot of their resistance capability. The other option is the onlays or the overlays. They can be made of ceramics or composites and they are cemented like in the manner of normal composites, yani etching, bonding, and dual cure composite resin cement. They are indicated when there is two walls of tooth. They are remained and they are intact, and the thickness of them must be 1.5 millimeter in order to be indicated. For the full crown is indicated when there is a great loss in the tooth. For a full crown, the ferrule must be at least 2 to 3 millimeters, which is the dentinal axial wall height. The axial wall must be parallel. The restoration must completely encircle the tooth. The margin must be on a solid tooth structure. The crown preparation must not invade the attachment apparatus, which means the soft tissue and the periodontal around the tooth. Not every endodontically treated tooth needs a post, and we will see when do we put a post and when do we not do it. The metal threaded post should not be used. It increases the vertical root fracture a lot. So the passive post that retention is dependent on the cementation is more practical. We need a 6 millimeter of root canal length in order to put the post. The root canal must be longer than 6 millimeter, but I mean that 6 millimeter is the post length. The fiber post is double cured cemented with and its survival rate reaches to 98%. It is considered the most retentive with the least stretch generated on the canal walls. It improves the distribution of forces applied along the root and decreasing the risk of the root fracture due to the elasticity that the fiber posts have. The author does not support the zirconia posts, and he is saying that they are too brittle, and the rigidity of the zirconia affects the root negatively, and it may results in a fatting and in fracture at the end. But fiber post has a failure rate of 7% after 7 years of getting loose. We usually cement the current post, the metallic one, with zinc phosphates, and the fiber post with the dual cure cement, resin cement. New restorations should not be placed on abutment tooth with a questionable endodontic prognosis. These are the rules to do the to choose the restorative material. A class 1 restoration where we have a minimal amount of tooth loss, we can do a direct composite restoration. If we have a one proximal wall that is lost, we can do an inlay or a composite restoration. If two are lost, we can do an inlay. If more, 3, we do a full coverage crown and empower it with a post. The post does not increase the strength of the root, but it gives us a retention for the crown restoration. So if we have half of the tooth structure that is left, we use a composite core fiber post, and if 2/3 of the coronal structure is lost, we use a core and metal post. Because the metal posts are more rigid and they can compensate the tooth structure that has been lost and prevent any future fracture that it may be possible. 2 to 3 millimeter of cervical tooth structure are the must be present in order to use a fiber post. A non-vital anterior tooth that had lost significant tooth structure required restoration with a crown supported with a core and post, which the walls are thin. But this is for the anterior teeth. For the posterior teeth, they came to a conclusion that if we have a remaining wall that is 3 to 4 millimeter of height, the buccal and the lingual walls, and their thickness is 1.5 to 2 millimeters, we do not need a post with the crown. But for the anterior teeth, if there is a loss, we need a post and crown. For the posterior, we can retain only with a crown without a post if we said that these two conditions are applied. We can do a crown lengthening in order to increase the height of the crown. Now, let's go along some clinical procedures on what can we do to restore an endodontic treated tooth. The first of all is the internal bleaching. With that, this is the first step, and this is the last. That it has previous restorations, so we removed the restorations and we did an internal bleaching, mixing 3% hydrogen peroxide with sodium berberite in 2 sessions. Each session is 10 days apart. We closed the tooth with a temporary filling. After after we get the color we wanted, we put a layer of glass ionomer and finished the restoration with a composite. We used an silicone index to repair this edge with a composite restoration. So this is the choice we can have for a posterior teeth that has a 3 proximal walls. Here direct composite restoration is indicated. We first put a glass ionomer or flowable composite, then we layer up the dentin composite and the enamel composite afterwards. Veneers is another choice when the tooth is not getting to the color we want, and when we are doing the internal bleaching and there is an old restoration that needs to be redone, so we can do the veneers. Our preparation is depending on the shade that we want to get. If the original tooth is A1, we take 0.3 millimeter of the tooth structure. If it is A2, we prepare 0.5. If it is A4, we prepare 0.9 millimeter of the buccal surface of the tooth. This is the Onlay overlay choice. We fill the chamber with flowable composite or a glass ionomer. Then we do the preparation of the tooth by that it must be 1.5 to 2 millimeters. When we do the Onlay overlay can be ceramic or composite. We do the cementation by etching first, doing the bond and using a double cure ceramic resin cement. This is the endo crown where we get benefit of the pulp chamber, but they're saying that their use has declined a lot at the past years. Also, the amalgam core is not used anymore. This is the case where we do a fiber post. This is the amount of the tooth that must be remained. We prepare half of the root or length, or 1/3 of the length of it. And this is the post and core that is metal. We prepare 2/3 of the root length. At the end, the treatment success relies on the effective coronal seal that will prevent the canal reinfection and an adequate restoration that will resist the functional stresses applied to the remaining tooth structure. So we must take the decision based on the remaining tooth structure, and our goal is to get the coronal seal in order to preserve the root canals from the reinfection that may happen. Assalamu alaikum. Mechanical loss of the dental tissues are a result of caries or access cavity preparation, and root preparation also is what weakens the tooth and make it fragile. While the changes that occur in the dentin as a result of age, like dentinal sclerosis, or as a result of the loss of dentin water or chilton with canal rinsing materials, are all secondary causes that do not have a significant effect on the dentin. Reconstructive options: the direct composite. When the tooth loss is little, the new generations of composite are able to reach a hardness equivalent to that of natural dentin, but the composites must be applied in incremental technique to avoid the shrinkage. Onlay overlay. It is indicated when there are sufficient dental tissues, at least two walls with a thickness of 1.5 mm, and it is either made of composite or ceramic, and it is cemented with resin cement after etching and bonding. Internal bleaching. As a result of the color change that occurs in the endodontic treated anterior tooth, we mix hydrogen peroxide and sodium barbitide powder and apply it in 2 sessions within the pulp chamber. Each session is 10 days. Then we finally restore it with a composite after reaching to the desired color. Veneers. When the internal whitening does not succeed due to the dark shade of the tooth, and when there is a previous restoration on the front tooth that needs replacement, veneers are recommended, and the thickness of the preparation is dependent on the color of the tooth. Full crown. In posterior teeth, it is indicated most of the time without being supported by a post. As for the anterior teeth, there must be a post when there is a dental loss of more than half of the dental tissues. It needs a ferrule with a length of 2 to 3 mm and a wall thickness of 1.5 mm. Metal post and core. It is indicated when 2/3 of the dental tissues are lost. It ensures parallelism in the case of multiple teeth restoration and facilitates the insertion line of the bridge. It requires preparing 2/3 of the length of the dental root. There is a risk of post-filling gap, which exposes it to subsequent failure as a result of the void that may allow bacterial accumulation. The fiber post. It is indicated in teeth that have lost half of its structure. It is cemented with dual cure resin, and it needs a third to half of canal preparation of the root canal length. Post loosening may happen after 7 years of cementation.